Welcome to The Explainer. Today we're breaking down the clinical guidelines on early pregnancy loss. Now, this can be a really tough and confusing experience, so our goal here is to give you a clear, supportive overview of how it's diagnosed, what your options are, and what the path forward looks like, all based on the official medical recommendations. So, first things first, it is so important to understand that while this experience feels incredibly personal and isolating, it is unfortunately very common. The data shows that about 1 in 10 of all clinically recognized pregnancies end in early pregnancy loss. Okay, so to make sure we're all on the same page, what exactly are we talking about from a clinical perspective? Well, early pregnancy loss is the medical term for a non-viable pregnancy that's inside the uterus and happens within the first, say, 13 weeks. You've probably also heard it called a miscarriage, but we'll stick with early pregnancy loss just to be clear. Here's how we're going to walk through this. First, we'll talk about the basics of the experience. Then, and this is crucial, we'll look at how a diagnosis is actually confirmed. After that, we'll dive into the 3 main paths for management, compare them, and finally, talk a little bit about what comes next. All right, let's jump right into our first section and get a handle on the fundamentals of what's going on here. One of the biggest questions is always why? Why did this happen? And as this chart shows, about half the time, the cause is a random chromosomal issue with the fetus. This is such a critical point because it means the loss was completely spontaneous. It wasn't caused by anything anyone did or didn't do. The other 50% of the time, well, the causes are either varied or just unknown. Now, the source material does point to 2 main risk factors that can increase the chances of a loss. The first is what's called advanced maternal age, and we see the frequency really tick up after age 35. The second is having been through an early pregnancy loss before. Okay, let's move into our second section, getting the diagnosis. This is an absolutely critical step. And as you're about to see, the clinical guidelines are designed to be extremely cautious, all to ensure 100% certainty. This is often the most stressful and emotional part of the whole journey, right? That waiting, that uncertainty. So how do doctors get to a place where they can say with absolute confidence that a pregnancy is non-viable? Well, the reason for all that caution is simple, and it's so important. It's to protect a potentially viable pregnancy. The rules are intentionally conservative because the absolute last thing anyone wants is to make a tragic mistake and interfere with a pregnancy that could have been okay. This slide shows you exactly how they get to that certainty, using ultrasound. You can see it's split into 2 columns. Look at the one on the left. These are the findings that are diagnostic. They confirm a loss. For example, if an embryo measures 7 millimeters or more, but there's no heartbeat, that's a definitive sign. But now look at the column on the right. These findings are suspicious, but they aren't conclusive yet, like an embryo smaller than 7 millimeters with no heartbeat. In those cases, a follow-up ultrasound in about a week or so is absolutely required before any final call is made. So once that definitive diagnosis is made, the conversation totally shifts. It's no longer about if, but about how. And the guidelines lay out 3 main ways to manage the situation. And here's the roadmap of those 3 pathways. You've got expectant management, which is basically watchful waiting. Then there's medical management, which uses medication. And finally, surgical management, which is a procedure. Let's look at option 1, expectant management. This just means letting the body pass the pregnancy tissue on its own time. The big plus here is that it avoids any kind of medical or surgical intervention. It works in about 80% of cases. But the catch is, it can take up to 8 weeks, and you just don't know when it's going to happen. Okay, path number 2 is medical management. This is where you use medication, usually something called misoprostol, to get the uterus to contract and help expel the tissue. It's a non-surgical way to speed things up compared to watchful waiting, and the success rates are pretty good, around 84%. And that brings us to the third path, which is surgical management. This is a minor procedure, often called a suction D&C or uterine aspiration, that empties the uterus. If you're someone who wants the process to be over quickly and predictably, this is the most direct way to do it. And a lot of times, it can even be done right in a doctor's office. So you've got these 3 very different paths. Now, let's actually put them side by side. It can really help to see the key differences when you're thinking about making a choice. This slide really zeroes in on the 2 active management options, setting aside watchful waiting for a second.
With medical management, the whole thing happens at home, over hours or maybe days. You avoid a procedure, but it's less predictable. On the other hand, surgical management is a scheduled event, all done in one day. It's by far the most effective and predictable option.
And when you see it like this in a bar chart, the difference in how effective they are really stands out, right? Expectant management works out about 80% of the time. Medical management bumps that up a bit to 84%. But then you see surgical management, which is effective in about 99% of cases right off the bat. So you might be thinking, what about the risks? What about complications? Well, here's the crucial takeaway. All three of these options are considered very safe. The risk of serious complications, like heavy bleeding or an infection, is really low. We're talking only 1 to 2%. And just as importantly, that small risk is about the same no matter which path you choose. All right, so after the physical process of the loss is complete, there are naturally a lot of questions about what comes next, about recovery, healing, and future plans. Let's see what the guidelines say about that. This slide basically answers the most common follow-up questions. For instance, if your bull type is Rh negative, you'll get a shot of something called Rh immune globulin. Thinking about contraception? You can start that right away. Want to try to conceive again? The evidence shows there's no medical reason you have to wait. And finally, a big workup to look for underlying causes, that's usually not recommended until after 2 losses in a row. This is another really critical point to hear. The evidence is just clear on this. Right now, there is nothing that's been proven to prevent an early pregnancy loss from happening. Things you might have heard about, like bed rest or taking extra vitamins, they just haven't been shown to change the outcome. And that really reinforces that this is not because of something you failed to do. And we're going to end on this final point, which comes straight from the ACOG guidelines, and I think it's incredibly empowering. Basically, your long-term health outcomes are the same no matter which path you choose, expectant, medical, or surgical. And what that means is that the best choice is simply the one that feels right for you, for your personal situation and your preferences. The most important thing is making an informed decision that you are comfortable with.